You guys see the screen? Ready to go?
Yep. Thanks again for being here tonight. Appreciate it.
Yeah, definitely. So this is talk about management of spinal cord injury, and we talk a lot about trauma classifications, management options, surgical treatment options a lot of the time. So this will actually mostly focus on kind of the pathophysiology of spinal cord injury itself and other treatment options, like outside of surgery, other topics that we don't usually talk about. So this is to take some time to do that. Let me, so we'll talk about epidemiology, pathophysiology, treatment of acute injury, what the role of glucocorticoids are currently, and the history of it, MAP goals, consideration of that, as well as surgical timing. All these are pretty controversial areas, and it's a difficult area to study, hence why it still remains controversial. And then also the emerging role of neuroprotective agents and ongoing trials. So, it's hard to estimate global prevalence or global incidence of spinal cord injury. A lot of these things just aren't kept track of very well, especially in developing countries. In places like the United States and organized trauma sort of referral centers, kind of like in Canada or Japan or Germany, there's better statistics. Here in the USA, we have approximately 54 cases per million people. That equates to 17,000 new cases in the US per year. And that means about 500 cases in the Chicago metro area per year. And that's split over how many level 1 centers we have here, right? So we have plenty. There's about 282,000 living in the USA currently with spinal cord injury, 3 to 4 times more prevalent in males. And the median age is expected to increase over time. As you can see, in the 70s, median age was 29 year, and 2016, 42. The etiology of the spinal cord injury, vast majority is blunt trauma, 42% vehicle accidents, 26% falls, and sports account for 7%. Penetrating trauma, about 15%, and other. I think in this other also includes, things like infection or other causes of spinal cord injury. About 30% present with incomplete quadriplegia, 25% with complete. So it's like kind of a Asia A. And the cause of death in spinal cord injury victims, leading cause number 1 is pneumonia. Second is pulmonary embolism, then sepsis and renal failure as well. Interesting stats. This is from one, I forget what this website was, the spinal cord injury website that kind of tabulates, every few years they tabulate kind of the data that they have over the last 10 years. Interestingly, 20% of patients are employed at the time of their injury, and this drops only 10% to 11% at 1 year after injury, interestingly. And then 20 years after injury, they found that 35% are actually employed. So it actually goes up a little bit. Whether it's the same job or a different job, I would have to imagine something different. The other thing is the lifetime costs are exceedingly high. You can imagine a high tetraplegia patient, the amount of estimated lifetime cost of care by the time they're 50 years old, it's $2.6 million. And an Asia D patient is $1.1 million. So that even a minor, or I guess less severe neurological deficit is still pretty expensive to take care of. And so we always think about the primary injury, right? There's, the mechanical reason why the spinal cord failed. And here in this case is like a flexion retraction injury, bilateral facet dislocation. That's like the failure of the spinal column. We know, this facet capsule is disrupted in the back, disc disrupted in the front, and you can imagine it's pinching the spinal cord. So that's the mechanical injury. And what it results is disruption of the axons. That's kind of the primary injury, right? The neural circuit, the signals aren't working anymore. The blood supply is disrupted, so the axons aren't getting nutrition they need. And also the supporting cells, like the glial cells, are also injured. And then because of this, pathways that are started in, axonal injury, the apoptosis pathway they kind of learn about, you get immediate death of neurons and the glial cells. You get generalized swelling in the gray and white matter. So that's kind of a good picture depicting that. In the acute stage, we had the mechanical injury. Then you move on to like the secondary injury, and a lot of the neurologic deficits can also continue to occur because of secondary injury. So when you have vascular dysfunction, so lack of blood supply, you're going to get edema, secondary to ischemia in the area. Interestingly, there's a when the axons are not working well, they're not able to maintain their voltage kind of potential across their membrane. There's massive electrolyte shifts. They start randomly firing, and they get this glutamate mediated excitotoxicity. So like every synapse kind of fires randomly, and so it's just a kind of a hyperexcitable phase. And then you imagine metabolism's not working properly, cells can't clean up all these cellular metabolites. Probably there's free radical generation. This all leads to activation of apoptotic pathways. Eventually, especially the area of primary injury that you see here, that kind of dies and it becomes a fibrotic scar. And then when we think about types of spinal cord injury, we'll kind of delve into the different types that you guys probably learned about, in medical school and stuff like that. But we think of this largely classifying them descriptively. A is the level of injury, because that kind of gives, when we communicate with each other, kind of paints a picture of what their function will be, and the degree of dysfunction, and we'll talk about the kind of classification as well. To understand that, you should at least get like a basic understanding of the relevant functional anatomy of the spinal cord. So, this depicts the gray matter here in the middle with all the cell bodies, and then the white matter surrounding, including all the descending and ascending pathways. So the stuff in the green are the ascending tracts. You guys are familiar with the dorsal columns there. Those are important for proprioception and position. Then you have in the descending tracts, what are important to know are the corticospinal tracts, the ventral corticospinal and the lateral corticospinal tracts. Those are the main motor pathways. And then reticulospinal tract also contributes to motor. Spinothalamic tracts on the ascending tracts, forgot to mention the ventral and the lateral. These are important for pain and temperature, and also deep pressure. So talking about the types of spinal cord injury, we have complete spinal cord injury. So that's lack of any motor function or any sensation below a certain level. Incomplete means that there's some residual either sensation or motor function. There's several incomplete spinal cord syndromes that present with a characteristic sort of distribution. You guys are all familiar with central cord syndrome. There's also anterior cord syndrome, posterior cord syndrome, Brown-Séquard, conus medullaris, and cauda equina. Central cord syndrome is probably the most common type that we see, most common incomplete spinal cord injury. Typically occurs with a patient, an older patient who either has pre-existing degenerative disease causing stenosis. They fall by hyperextending their spine. When they hyperextend their spine, they can pinch their spinal cord. With the hypertrophy, ligamentum flavum, the discs. There's just not enough reserve in the canal, and that mechanical compression can set off a spinal cord injury. You can have a central cord syndrome without. Sorry, my dog came in here. You can have a central cord syndrome without a mechanical failure of the spinal column. So it can be associated with a fracture or not, or an entire spinal column. So that's one thing to keep in mind. And typically it's characterized with more prominent sort of upper extremity compared to lower extremity weakness. And the other kind of burning neuropathic pain that they always complain about, that's from the disruption of the spinal thalamic tract. Anterior cord syndrome, this typically occurs with disruption in the interspinal artery. It can be in the setting of like an infarct, where people are undergoing classically things like vascular procedures, or just other reasons for, maybe vascular dysfunction and infarcting their interspinal artery. You get characteristic loss of motor function, but preservation of the dorsal column. So you have like proprioception and vibratory sense and 2-point fine touch. So posterior sequoia syndrome is pretty rare. Obviously, it's where the dorsal columns are not working. Brown-Séquard, I have yet to see in any clinical setting, but obviously caused by penetrating trauma and hemitranssection of the cord. So you get ipsilateral loss of motor function and contralateral loss of pain and temperature because the spinal thalamic tracts that
We actually had a patient earlier in the year with Brown-Séquard. It was a stab wound to the back of the neck, kind of like what they teach in med school. It's kind of cool to see. But,
oh, really?
yeah, we had one. Yeah,
Wow.
one patient. Yeah.
I missed that. Huh. Did it get any motor function back?
So Sue was on call. The knife actually nicked the dural sac, but didn't actually touch the cord. So the guy came in with complete motor deficits on one side, pain and temperature on the ipsilateral side. He pretty quickly regained motor function back on the ipsilateral side, but the sensory took a lot longer to come back. I saw him back in clinic. Probably, I can't remember if it was a 6-week or the 3-month follow-up, but was still having a few sensory deficits, but motor pretty much recovered by then. But just a small nick in the dural sac on MRI, and he had a kind of pseudomeningocele from that too that we were following. But interesting to see. Yeah, not something you see very commonly. So
Yeah.
Yeah, we learned that pseudomeningocele can heal on its own, right?
Yeah.
You know, over time. So yeah, it leaked for a while, I think. But
yeah, we had a couple
then it just
serial
closed up.
MRIs. Yeah, he developed meningitis initially. That was treated for that and ended up doing okay, fortunately for him. So
Pretty interesting. Cool. Something I won't forget. Talk about conus medullary syndrome, also pretty rare, but it's where you get compression to the distal aspect of the spinal cord around the T12L1 area, and this can result in proximal lower extremity symptoms, bowel and bladder dysfunction, sexual dysfunction, and then loss of sensation in perineum. Aquinas syndrome, you guys are all familiar with. This isn't really a cord injury, but it's a nerve root injury at sort of the extreme. You could have variable sensory and motor deficits, and are more characterized with urinary and or bowel incontinence and loss of rectal zone. So we'll talk about treatment of acute injury and just kind of going over the studies you guys should be familiar with and why or why not, why we don't use steroids. So methylprednisolone, SS stands for sodium succinate. It's kind of the most highly studied in the setting of spinal cord injury, starting in the 80s with randomized controlled trials. It was chosen because specifically methylprednisolone has a significant effect on reducing membrane lipid peroxidation, and so stabilizing injury neuronal excitability from that standpoint. NASCUS-1 was a first trial, and if you can remember one thing, NASCUS-1 is for assessing low dose versus high dose. Only had 256 patients. Low dose was 100 milligram bolus and then 25 milligrams Q6 hours for 10 days. High dose was 1,000 milligrams bolus, so 10 times higher, and then 250 milligrams Q6. I don't really know how they chose those, but presumably there's some data behind it. They would administer this for 48 hours, and then look at their primary outcome was look at the motor and sensory exam at 6 weeks and also at 6 months. They found, their primary outcomes, no difference. But they did notice with the high dose group, 3.1 increased relative risk of early fatality. So that means less than 2 weeks. And then also 3.6 times higher risk of wound infections. Obviously, the main limitation here, there's no control group and only half the group followed up. So it's pretty, low kind of powered study, even though, it did find 2 significant findings. And no control group, so hard to really compare with just this one cohort. NASCUS-2, so the next stage of this was to include a control group, and so they did. They also changed the dosing, so it's different from NASCUS-1 in that sense. So 30 mg per kg loading dose. So if you take that to like an average 70 kilo person, that's 2,100 milligrams, right? That's like double the high dose that we saw in the last one. So it's a much higher starting loading dose, and then you have 0.4 mg per kg per hour for like 23 hours. Naloxone was another arm of the study, and naloxone, I believe, was chosen because of some in vitro data, again, showing some stabilizing effects on, I believe, either neuronal injury or like membrane degradation. And then finally, a placebo arm. And they looked at the same endpoints. Here they found that actually the high dose group, when they administered people that got treatment within 8 hours, had improved outcomes of motor, light touch, and pinprick at both the 6-week time point and 6 months. And however, they did this in a post hoc manner. It wasn't a predefined methodological goal going into the study. So that was a major point of criticism with this study. And then finally, NASCUS 3, years later, I looked at, again, a 3-arm study, and this was looking at duration. So they looked at high dose for 24 hours, high dose for 48 hours, and then Trilizad for 48 hours. And again, this was Trilizad was chosen because of a decreasing peroxidation on the neural membrane. No non-treatment control here. Here, the 48-hour group showed improved motor recovery at 6 weeks and 6 months compared to 24 hours, but the treatment had to be initiated between 3 to 8 hours. But they also noted increased complications, including severe sepsis and pneumonia. So again, in this trial, despite the fact that the the high dose long duration showed better motor recovery, there's also more complications. And this kind of arbitrary 3 to 8 hour window that it had to be administered. So a lot of criticisms for these studies, right? They're not perfectly designed. You know, arguably it's a hard thing to study. Questionable statistical methods, all these post hoc analyses really kind of invalidate some of our conclusions. You can draw from that appropriately. So, and incomplete data reporting, if only like about half of people followed up, then kind of hard to get good outcomes from that, or good conclusions. And then while the motor scores actually improved, there wasn't any demonstrable benefit in patient functional gains. And here are the complication rates. There's 1.5 times increased risk of hemorrhage, 2 times risk of wound infection, 3 times pulmonary embolism, severe pneumonia and severe sepsis, 6 times increased death rate due to respiratory complication within the first 48 hours. That's huge. Like that in and of itself, would make me think twice before administering high dose steroids, especially to an older sick person. So in 2017, AO guidelines suggested if it's more than 8 hours, after presentation of the injury, steroids no benefit. If it's less than 8 hours, you can consider a 24-hour infusion. And again, that's a weak recommendation. And I think that should be made in a case-by-case basis. For example, a young 20-something-year-old with no medical history and minimal comorbidities, very different from an 80-year-old. And do not suggest offering a 48-hour infusion because of those high risk rate, high complication rates. Next one that we always consider when we're in the ICU, we always talk about MAP goals. We always recommend maintaining between 85 and 90 millimeters of mercury, right, for 7 days, 5 to 7 days. This is a level 3 recommendation by the ANS and CNS. They looked at a 74 patient cohort that followed up 30 days post-injury. So they looked at cervical and thoracic, and looked at the patients that improved more than 1 ASIA score had higher average MAP scores, you can see in the purple line. Yep, that was published in 2015. We're looking at this, another study, another risk factor that could be indicative of poor early neurologic recovery. This is a retrospective case control study of 92 patients, looking at whether chronic hypertension was a risk factor. And this study noted that patients with hypertension had a much higher decline in their ASIA score compared, the ASIA motor scores compared with those without hypertension. So consideration of people with hypertension may need a higher MAP target, but that really hasn't been, kind of delineated otherwise in other studies. This one out of shock trauma, interestingly, kind of looked at 105 prospective patients of cervical and thoracic spinal cord injury, and showed that the number of episodes that they encountered in their inpatient setting, like the number of hypotensive episodes, didn't really correlate with their long-term, or didn't really adversely affect their Asia motor score. But they didn't follow these patients to their 6-week, 6-month kind of time points like some of the other studies did. So it's hard to extrapolate much from this. I mean, from our standpoint, when we think about it, even transient hypotension could theoretically affect, an injured sick cord. So this, I think, is an interesting concept, but probably needs to be studied in a more rigid manner if we're to take away anything from this.
Did they report the duration of hypotension? Like how long the patient was hypotensive? Because you'll see fluctuations minute by minute, right?
Right. I believe I gotta go back and look at this because it's been
Fair
like
enough,
years.
yeah.
Look at it. I gotta look at that.
But it's probably prolonged hypotension that matters more than just brief episodes, right?
Yeah, I would think if they're looking at an episode, they have to quantify that episode for being
Yeah.
a certain time. I'll look into that.
I mean, for me, the only time I've ever seen a patient lose cord function, in the hospital during their care,
Mhm.
I had a post-op patient years back who had a low thoracic cord injury, incomplete. We operated on him, he was stable, and then post-op they had like sustained hypotension. He was like hypotensive for like 6 hours, and went from an incomplete to a complete.
Oh,
And we freaked out. We scanned him, we imaged him, everything looks clean. So it ends up absolutely being a perfusion issue. And again, I think this is why we really push hard for these folks to be in the neuro ICU. We push hard for the anesthesia critical care team to manage them, because they tend to track the blood pressure a little bit better than like the SICU.
mhm.
Right.
Yeah, I agree. I think it makes sense. Like physiologically, you need like a sustained amount of hypotension for several hours, right? We'll look into that. Another study looked at MAP maintenance in the setting of penetrating cord injury, and this was pretty low N, but they found that only 1% or 7%, 1 out of 14 patients experienced neurologic recovery, and this is in the penetrating group. So compared with blunt injuries, which showed 36% improvement, and 10 out of those 14 experienced cardiogenic complications from being on pressors. So their conclusion was that given poor prognosis for improvement in penetrating cord injury of neurologic improvement, that maintaining MAP goals may not be the wisest thing, and you got to weigh it against the effects of maintaining them on vasopressors. And then they did suggest if vasopressors are needed, dopamine should be considered or given priority over phenylephrine, presumably for cardiogenic and probably renal implications too. And then surgical timing. Lastly, this is an interesting area of study for spinal cord injury, because we all get taught the same time as cord, right? So like as soon as someone gets injured, while they're being transferred in, I like to know exactly when the injury happened. For example, that lady with bilateral facet dislocation that we got back in October, she was drinking that night, that Halloween night, fell probably around 2 a.m., woke up at 6 a.m. No one at home had noticed probably this presumed injury. So I assumed that she got injured at 2 a.m., but by the time she went to a hospital that morning in Indiana and transferred to Northwestern, got imaging, it was already like 2 p.m. So it was like 12 hours out. Still early enough, but you never know. Like that's probably ideal scenario for her. But it's always good to get an exact timing, especially if those studies before were saying you have to administer steroids within 8 hours. It's really hard to get a patient into a tertiary care referral center within 8 hours. But so this STASCA study looked at 313 patients as a multi-center prospective study, trying to divide patients between an early group and a late group. And that was defined as, I believe, within 24 hours or greater than. And so the mean time to surgery in the early group was 14 hours and the late group was 48 hours. And their primary outcome was looking at the Asia motor score, Asia score change at 6 months follow-up. The early group had younger patients, more severe initial AS grade. Obviously, with the vast difference in their two groups, they noted that the early group had 2.8 times more likelihood of improving 2 grades in their Asia score, 1.4 times more likely to improve 1 grade. Now, obviously, the limitations here are that are they really the same cohort? You can't really, in my mind, you can't really make them equal. Asia D's patients can't really improve to AS grades, and there's more of those in the late group. So, and also one of the questions is like, what role did spinal shock play in the early group? How many were actually true Asia A's or Asia B's? So again, a difficult topic to study, but this is about as good of a study we're going to get in like orthopedics or neuro, a large multi-center prospective study in this. Canadian study replicated the same thing. They looked at less than 24 hours or greater than 24 hours after injury with more patients, 470. They analyzed motor score recovery at 3 to 6 months. They found no meaningful improvement for Asia A patients, but for Asia B, C, and D patients, 6-point motor score improvement for the early group and decreased length of stay. So that's pretty interesting. And then for the AO spine guidelines from 2017, for acute spinal cord injury, we should consider stabilizing within 24 hours. It's a week recommendation. One of the things here, I think that could be controversial when it gets your takes, Dr. Patel and Dr. Su, is central cord syndrome in the absence of any structural pathology. So no injury to the spine, central cord syndrome, should we watch and wait or pull the trigger early on surgery? That's one thing I haven't really decided on. And I think more and more, maybe I'm leaning towards obviously assessing the patient and discussing with them. If they're sick, then we can probably wait and see and do it in a delayed fashion. But I'll throw that out there.
Wellington, what do you think about in that scenario? Kind of acute traumatic myelopathy, stable spine.
Yeah, it's an important topic for sure. When we were training, you'd find a lot of surgeons who would say, yeah, I operated early on these folks and I got a complication and they did worse. But how do you really know if they would do worse? Because you don't really know what they're going to do without, surgery. But that was the concern, is that they can get complications early on. I think we have to make sure that we're talking about classic central cord syndrome, because we call a lot of patients that come through the ER with central cord, but in reality, they are a dense, incomplete spinal cord, like their lower extremities don't work very well, right? In that scenario, yeah, that's not a true central cord. That patient needs a decompression right away, because their spinal cord injury is more severe than your classic central cord. But assuming somebody has classic central cord where they're ambulatory and they just have dysfunction of their arms, yeah, I'm very conservative with that, because that indicates that this cord has function and has decent function in the lower extremities, but in the upper extremities, which means that the upper extremity has the potential to heal and to regenerate on its own without surgery. So that's kind of how I look at it. But I do think that if a patient were to push for it in that scenario, I would also be agreeable to decompressing them early too. But I generally am conservative in the classic central cord patient. How about you, Al?
Yeah, I think the most critical part of that discussion is really defining, what do you mean by central cord syndrome? So we have a paper that's going to come out in the Yellow Journal soon, trying to redefine this a little bit, right? Classic central cord syndrome is somebody with a very discrete neurological examination, right? And the original papers actually report people based on the neurological examination with or without instability. So some of those folks in the original paper had like dislocations, and they defined them as central cord. And so I think modern state, current state, we talk about central cord as though it's someone with a neurological deficit, cord level injury, who doesn't have instability, who doesn't have, some dislocation, translation injury, maybe has some congenital stenosis or a spondylotic stenosis, right? That's, I think, how we oftentimes talk about central cord. So they don't present with just hand paresthesias, distal more than proximal weakness, upper more than lower. They present like a dense, incomplete injury, right? And so I think we treat them as incompletes. There's a subset of patients in that population who, because they don't have instability, probably start to improve neurologically rather rapidly. And these are the folks who, may come in with a fairly dense neurological deficit beyond the boundaries of a central cord syndrome. But then during their stay in the ER or within the first 24 hours, they start to evolve very rapidly out of that. And they may go from like an Asia C, Asia B to C to like an Asia D. That's an interesting subset of this patient group with dense, incomplete injuries that happen to be in evolution improving that I might wait on. Otherwise, a true classic central cord, if it's relatively mild degree of neurological impairment, I would wait. But if I'm not sure, I'm going to tack towards early decompression. And I think the other part, just from a bit of history standpoint that Dr. Su mentioned, you look at the Staska study, right? And to many of us now, that seems obvious. But when that study was being done and randomized, like in the mid 2000s, it wasn't so obvious that, we were helping people who had cord injuries with surgery. And the question was, are we making them worse? So one of the key takeaways from that Staska study was that actually the number of neurological declines that occurred, in those patient groups was similar in both early and late. So that early surgery wasn't creating harm, for patients. So sorry, long answer. Short answer is probably operate on them unless it's a pure play central cord syndrome, or they're rapidly improving.
Yeah, no, that's a good point. And I think for fellows and residents, it's like we should kind of reframe how we're thinking about it now as well. Like talk about, instead of calling it a central cord syndrome, calling it, like you mentioned, like acute traumatic myelopathy, and we talk about whether it's like a dense incomplete spinal cord injury versus like a true upper extremity kind of injury only.
Yeah,
So
I think we want to hone in on central cords. For the problem is the literature looking backwards is going to be very muddled, right? A lot of people are going to be lumped into central cord for all these reasons. So moving forward, we probably want to talk about somebody with central cord syndrome really being somebody who has a classic neurological exam of central cord versus somebody with a incomplete cord injury in the setting of, severe stenosis as being somebody more with like an acute traumatic myelopathy. That's the language that Failings and the guys in Toronto are pushing. It's the language that the folks in Canada are pulling in. And so I think we'll see the conversation trend in that direction.
Yep. Makes more intuitive sense. Now moving on to kind of a little bit more of the, I guess, not esoteric, but a lot less clinically applicable stuff right away. We're talking about neuroprotective and neuroregenerative strategies. I think it's very important. People are working on this to develop kind of the next stage of treatments. As the saying goes, it's a good time to be a rat with spinal cord injury because there's some promising, treatments out there. Kind of going back in time until now, there's a lot of things out there. Minocycline, you guys are familiar with, is a tetracycline. And it's interesting because this actually crosses the blood-brain barrier. And it's one of its effects is that it can inhibit apoptosis or inhibit the caspase upregulation in that pathway. So the thought is administering this during acute spinal cord injury can decrease the amount of spinal cord damage that's done, or axonal damage. Clinical trials demonstrated utility, for other neurodegenerative diseases, including ALS and Huntington's disease. Here you can see kind of an interesting comparison with tetracycline and minocycline. With administration of tetracycline at the level of the lesion, minocycline performed better in terms of repairing or preventing the amount of apoptosis of the gray and white matter. And I guess the close-up histology shots kind of show the same thing. They're pointing towards, the so glial cells that are kind of supporting it. Looking towards like a phase 2 placebo-controlled randomized control trial, acute spinal cord injury with 52 patients. They showed 6 points greater motor recovery overall in the minocycline group, 14-point improvement specifically in the cervical group. But there's still, and I haven't checked the latest on this on clinicaltrials.gov in terms of where this is at. A lot of the spinal cord trials that got started in the 2010s have been terminated because of either non-superiority compared to placebo or just lack of funding, but mainly because of non-superiority. We'll kind of go into that. Riluzole is another interesting drug. It was mainly been investigated in ALS, and it works by blocking sodium channels near the synapse. And because it does that, it decreases, the release of glutamate. And glutamate, as we talked about, is synaptic potential or potentiator. So it kind of increases the postsynaptic kind of excitability. So by administering riluzole, sort of stabilize nerves from keep firing at their synapses. So another potentially useful drug in, I'm not sure how it works in ALS, but it makes sense in spinal cord injury, right? Because you want to prevent kind of these nerves from continually firing. Animal studies seem promising, looked at improved behavioral and functional outcomes. And then this RISCUS trial was started, and phase 1 data demonstrated larger improvement in motor scores in 90 days. And then a phase 2b, phase 3 clinical trial was started looking at effect on spinal cord injury, in subaxial cervical spine. This was recently terminated in October 2020, looking at clinicaltrials.gov. And I believe this was also because they terminated because of non-superiority compared to placebo. Now, there's another set of neuroprotective agents that act on this pathway called the Rho-ROCK pathway. This is a pathway that's involved again in neuronal apoptosis. So a lot of these things come down to that. And this pathway is upregulated in spinal cord injury. So an inhibitor of this would inhibit apoptosis. So one such drug is Sethrin. And this is a drug that's extradurally applied. And they noted in a phase 1/2 clinical trial of 48 patients, 27-point improvement. I believe this is that same drug, Vertex. They halted the phase 2b for futility. This was back in 2018, and that's all I could find about it. And interestingly, you guys might be familiar with this. So repulsive guidance molecules, they're upregulated in neurodegenerative issues like multiple sclerosis, or in cases like stroke, TBI. And basically, they prevent axonal regrowth, limit remyelination, so inhibit kind of neural repair. So blocking these molecules is another interesting area of study. AbbVie developed this drug, lecanemab, that is actually, we are a center for like the randomized control trial. And just as an FYI, I think Jeff, but because you're added to that group, Dr. Ganju is running this trial, and if we get a acute spinal cord injury, I think within 24 hours, right, we should notify that team, because this is a IV drug they can administer for, I think it was 24 hours, right? 24-hour infusion for 48 hours, and it can be post-operatively too. So even if we're going to operate on the patient, depending on the clinical scenario, they can give it post-operatively in ICU. But basically, it's a monoclonal antibody that neutralizes these molecules. It has, promising efficacy in rat studies, looking at motor scores, as well as, histological studies, looking at neuronal length, their grip strength. And finally, moving on to the land of, autologous stem cells and, autologous Schwann cell transplantation. One study looked at sural nerve harvest for Schwann cells, injecting the site of spinal cord injury. Obviously, this is pretty invasive and really very little data on this. They did it on 6 patients, and 1 patient converted to Asia B. Another interesting area using chemical and tissue engineering, looking at the idea of scaffolds. So you have, and obviously when we think about scaffolds in peripheral nerve injury and like hand surgery and stuff, we're trying to bridge a gap for that nerve to repair. Same idea in the spinal cord. This is providing a pathway for those axons to regenerate on. Here, there's one trial started in January 2018 where 7 out of 16 patients were noted to have an Asia conversion in 6 months. Again, this is not a kind of a phase 3 or 4 trial, so there's no better level data. But this is kind of what it looks like. It's a very invasive procedure, right? Open the dura, implant in the direct area of spinal cord injury. Not anything that we usually do. This seems like there's a realm of neurosurgery. And the idea is, at least histologically, they can prove that rather than a cyst, you can actually have novel tissue that's created. So it seems like an interesting idea. Whether it's clinically would ever kind of work out is another story. So in conclusion, we know spinal cord injury is a devastating problem. One thing we should recognize, it's also very heterogeneous. So not all spinal cord injuries are created equal. And there's a lot of support, I think, out there for acute surgical intervention. There's not much support out there for steroids. I'd say there's good support for maintaining NAP goals for 7 days. And there's not much good evidence for these investigational things like investigational drugs or scaffolds, but being a center in this randomized control trial is pretty interesting and something to consider if we get the right patient. So with that, I'll end there a little early. We could talk about for like 5 minutes any questions you guys may have. Feel free to unmute and speak up.
Hey, Dr. Divi, I have a quick question. I've heard from my time in the military, people use mannitol for cerebral edema. And so I just was doing a quick Google search on it, and there might be something with mannitol and spinal cord edema. Have you heard of anything like that, or is there any,
No, that's an interesting concept. No, I have not come across that. I think in cerebral edema probably makes sense, right? Because they need to get it under a certain number, and that they monitor with like a bolt or something. But I wonder, it seems to make sense to me. We'll look into that.
Yeah, thank you.
Really nice job, Tree. Just 2 comments here. I'm really happy that my research career is built upon bone regeneration instead of nerve regeneration, because the concept of nerve regeneration is so complex that it makes it so difficult. Even if you see data and translational studies in rats and such, even the regeneration of nerve tissue, how do you really know that tissue is organized enough to transmit signals, down through the spinal cord and eventually, have some kind of clinical effect? But because we know that the clinical effect in rats really has not translated to humans very well. So that being said, I think it's important for us to recognize that after 100 years of research, we really don't have any good mechanism to improve patients with spinal cord injury other than surgery, MAP, or oxygen, and blood pressure. Those are the things. So when exciting new data comes out with, even at our institution, my collaborators have a very exciting nanotechnology scaffold that has been published in Nature, and it really is very promising in animal data. It's just really hard for, I think, any spine surgeon to be like, wow, that's actually going to work, because nothing has worked before. So we got to stay tuned, obviously. One question, you had a comment about dopamine versus epinephrine. And I think you made the comment on how dopamine was better for patients to achieve their MAP goals. Is that controversial, or is that well known? Because I think at Northwestern, we're treating our patients with phenylephrine pretty routinely.
Yeah, that's at least what the one paper talked about in terms of like if we're looking at cardiogenic effects or like renal effects, I think dopamine's better. Now, I don't know. I think most centers across the country, at least what I'm used to also from training at UFC and at Jeff, I think we use phenylephrine too. So I'm not sure if that's reserved for a certain case. I don't know enough about that. I should probably look into it.
Yeah, I think there's not, it's by no means a given. Again, it makes sense if you think about, two ways to raise the blood pressure, either constrict the vessels or make the heart pump harder. It makes sense to try to make the heart pump harder, except keeping in mind the cardiac implications of that. And it's worth a conversation with anesthesia. The last time I discussed this with them, at least even in the OR, asking them about, vasoconstriction versus sort of cardiogenic raising and blood pressure. The epi is easier to manage. It's easier to titrate on and off for them. And I think it's similarly easier to manage in the ICU. So that might be a big driver for why they trend towards epi use. There was one paper at CSRS that tried to look at it. And I don't remember, I'll have to go back and look at the abstracts, but it wasn't convincing, and the difference wasn't convincing. But that was with a relatively mixed sort of methodology. It wasn't a randomized study by any means. It was sort of a single site retrospective, case series basically, or cohort analysis. So, yeah, but it is a little humbling to see like this talk when I was a resident, 20 years ago, wasn't too different, except the new and exciting stuff we were talking about was Sethrin, and was stem cells and the stuff that's sort of come and then gone. The translation of this research to the human setting is extraordinarily challenging. You mentioned a few reasons. There's noise in the diagnosis, right, on the front end. Spinal shock being a big driver of noise. There's a lot of fragmentation of care. So cord injured patients go all over the place. Primary settings could be in a small hospital, a small like secondary trauma center, could be a tertiary center. In Chicago, we've got, I don't know how many, 6 or 8 tertiary, primary centers. And so they end up going everywhere, and it's really hard to recruit patients into clinical trials for that reason. And then the last one is that there's this ethical dilemma that pops up when it comes to cord injury research, which is, all these trials, if we really want to know if they're going to work or not, require a randomized protocol, right? And so if you're a patient with a cord injury, you don't want to be randomized. You want therapy, because we know nothing else really kind of works all that well. And so, gosh, anything we try could be an improvement, right? So it gets really challenging to randomize these patients in this setting. Not impossible, but just a real big challenge for all those reasons. So I wish I knew where this was heading. I think there was a lot of hope about 5-6 years ago that Riluzole was going to be a really good option based on the preclinical data. So that was really disappointing when they canceled the trial. And that was done because of an initial data analysis. And their initial data analysis showed non-inferiority, and so they canceled the trial for that reason. So it's sort of to be determined.
Sorry. Hey, Dr. Divi, you mind if I let me share my screen? I'll show these guys the images from that Brown Sicard patient. It's kind of interesting to see.
Yeah, sure. Yeah, go ahead.
Let's see.
And Riluzole was also like a tablet too. I think that was like kind of a cool thing about it.
Desktop share. Awesome. You guys see these CT slides?
Yeah.
Cool. Yeah. So this was a guy, he was like pretty young. I think he was like 19 or early 20s, came in, with a stab wound to the neck. They consulted us due to this lamina fracture on the right side. Had this initial CT scan and then MRI, which showed a few of these cross sections. You can see on the sagittal just to kind of nick in the cord itself, and then on these axials how it nicked the dura as well. And you can see the CSF starting to kind of leak out there in these cross sections. So his exam, let's see, going back, I saved these exams. So if you look here on the left, motor function on the right, 0 to 3 in the lowers, and where's the uppers? 0s and 3s in the uppers on the right as well. His sensation was also diminished too on the left side. That was more, he was more worried about motor initially. The sensation was more noticeable later as his motor function started returning. So you notice here again, motor functions improved. I think this was a day or two later into 2s and 3s, and then 3s and 4s, and even a couple 5s kind of by the time he left the hospital. And then this was one, they consulted, he developed meningitis later. So they rescanned him, showed this kind of pseudomeningocele from that nick in the dura. And then let me get out of this. So I have a side-by-side shot too. It kind of shows. So this was the right side was kind of the initial one. And then a repeat scan with the meningitis showed that pseudomeningocele is going down in size too. So that just kind of shows you that you can just kind of follow these peripherally as long as it's not leaking through the skin. These will tend to kind of close up on their own too. So I just thought this was kind of an interesting case that we saw something you talk about Brown-Séquard just because of the pathology in med school and residency, but you rarely get a chance to actually see it. So this was kind of cool to see. So
The before and afters are pretty cool to see.
yeah.
Yeah, and that was a pretty high injury too.
Yeah, he's super lucky that it wasn't worse than what it was for him. So
Yeah.
Thanks for sharing that. I mean, that's really cool. I've seen Brown-Séquard injuries, but usually associated with sort of weird atypical, fracture patterns where there's almost like a sagittal split
sure.
right in the body, and you get this shifting of the left and right columns of the spine away from each other. I've never seen this before, but that's really cool. Did he how far has he been followed up at all since he left?
Yeah, I saw him back at, I can't remember if it was the 6 week or the 3 month mark. I think it was the 6 week, and he was doing really well.
Yeah.
Just a couple of 4s out of 5s, but mostly 5 out of 5 on the right at that point. He still had a little bit of numbness, but he felt like it was coming back on the left side as well. But again, had a really great outcome given what he came in with and what this injury could have been for him. So
Yeah, he had some headaches, I remember, but his neurologic function was pretty much normal. So
yeah.
Wow. Very cool. All right. Sri, great talk. Thanks so much.
Yeah,
Any other questions
guys.
from the group? Otherwise, I think we covered it pretty well. I have nothing left to add other than I hope that in another 10, 20 years, we're not sitting and listening to the same talk. But that's
I would
the
save
challenge.
it just in case, Sri. You just save it because
Yeah,
it
just
could be the
save
same talk.
Just say it.
Yeah, exactly.
All right. Good night, everyone.
Thanks, Sri. Appreciate it.
Bye.
Thanks, Dr. Divi. Good night.
Yep.